and then an overview of doctors' views and the concerns that have been expressed, particularly for Northern Ireland doctors. So Cicely Saunders, back in '67, opened St Christopher's Hospice, and she said, amongst the various quotes from her, "You matter because you are you. You matter to the last moment of your life. We will do all we can, not only to help you die peacefully, but also live until you die." And I think that last phrase is very important. And it has been from a scientific basis that modern palliative care has developed. It's portrayed as being somehow sort of touchy-feely or whatever, but there is actually solid science behind it. Cicely described total pain. You can also talk of total distress, which has a physical component, and that you can treat with treatments and drugs and so on, but also emotional, social, and spiritual pain. If you don't address those, the person will still suffer, even when you're trying to deal with the physical, but also those other components in the blue boxes all enhance the experience of pain and distress. They make the pain feel worse. When you understand the pain and what to do about it, it feels less bad. And morphine does not kill the patient. It's there to kill the pain. You titrate up the level, you may need breakthrough doses, but the aim is to be above the pain, below the level of toxicity. Now, that same principle applies to all the medications that we use, that you titrate them up or down as needed. The proponents say, oh, but doctors are killing patients with morphine and hiding behind double effect. Well, they're not. Let me just explain double effect to get it out the way. You give something with the intention of a good effect. You know that there is a risk, which you try to minimize, of a bad effect, but you don't intend the bad effect. Now, morphine, it really doesn't happen in modern medicine, because if you monitor somebody's respiratory rate and it's starting to slow, you can just drop the dose of morphine. If they're sensitive to morphine, there are other medications that we can use. But take something like chemotherapy, which is in a way a clear example. You give the drugs, toxic drugs, intending to get rid of the cancer. You know that some people will get neutropenic sepsis, from which they might die, but we're not running around saying, well, there you are, oncologists are killing their patients with chemotherapy deliberately. So this is a kind of manipulation, really, blaming on medicine the fact that it is inevitable that people will die and they have good symptom control at the end of their life. It does not mean the doctor killed the patient. What is dying in the developed world? Well, for most people, it's not the sudden presence of death. It may be if somebody's heart suddenly stops, but it's the gentle absence of life as life slips away with their situation controlled. Palliative care itself needs to come in early, at the time that acute interventions happen. It is no good just bringing in palliative care at the dying bit, because you will have missed the opportunity to improve life earlier on. But we are often involved when things suddenly change, they deteriorate, become unstable, and we're there working in parallel with our acute colleagues. And the reason is because if you are going to narrow the gap, the deficit in people's lives, you need time to do it. And what you're trying to do is to help them reset their hopes and aspirations, improve whatever needs to be improved, and help them also reset reality. So it may be, classic example, I had it just a few weeks ago with lockdown, in the little window that we had, we brought a wedding forward for somebody who is terminally ill, for his daughter. Took a lot of fast arranging, but we did it fast with a special license. And it was a lovely day. But if we'd waited a week, she wouldn't be married now. And he will have died before he saw his daughter married, let alone walk her down the aisle. So we know, and there's scientific evidence, that early palliative care will improve quality of life, improve mood, and interestingly, people live longer, not only better. So actually, if people don't get good care, they just die of exhaustion. If they get good care, they live not only better, but they can live longer. Now, Cicely said, dignity is having a sense of personal worth. In other words, you have dignity, a feeling of dignity, because of the way that people behave towards you. Just think about it for a moment. If you've had an accident and soiled yourself, if the people that you're with go, oh, that's disgusting, you feel awful. If somebody says, oh, don't worry, that doesn't matter at all, just pop in the bathroom, I've got some spare clothes, we'll just pop that in the washing machine. Doesn't matter, come and have a cup of tea, and is nice to you, you feel much less bad about it. It's the way that people behave towards you that gives you your inherent sense of having personal worth. It's not the trappings of whether you've got a medal on you or a gold chain around your neck or anything. And how do we do that? How do we help people have a sense of personal worth? By listening to them, listening what they're frightened of. And you listen not only with your ears, this is the Chinese symbol for listening, but you listen with who you are. You listen with your eyes, picking up nonverbal cues by giving people undivided attention. And above all, you listen from the heart. So it isn't about telling people what palliative care is or is not in a theoretical way, as outlined in this bill. It's about listening to what they need, what their hopes and aspirations are, what their worries are, what their fears are, and dealing with those in a very personalized way. How do we make decisions? Well, individually, of course, it's mostly based on our feelings and our experience and our memories. But it's also based on those nonverbal cues. The sense of, well, I think I'm a burden, you know, the overheard conversation of, oh, look at the gas bill. We've got to keep it on because of grandma feeling cold. All those little things that go on, other bits of information that come in. And interestingly, when you look at the data from Oregon, feeling a burden or fear of feeling a burden is the main reason that people go and seek assisted suicide from their doctors or from other doctors if their doctors don't comply. And what do you need to make a decision to end your life? Well, it's the same as you need for any decision, except that this is the biggest decision that you could possibly make. And that is, you need accurate information that you can understand. You need the capacity, as a neurologist colleague has so clearly outlined difficulties with that. And it has to be voluntary. And voluntary means free of all pressures, those subtle little ones, those grunts in the family, the person exhausted of having to visit somebody, or saying, gosh, it's such a long way, I've got to go and see them. And they pick that up. That's coercive. So how good are doctors at all this? Well, on the select committee that I was on and was superbly clerked by Robert, we heard evidence. Diagnostic errors abound. In 1 in 20 postmortems, people were found to have died from something different to what was written on the death certificate. Not good. Prognosis, we cannot tell how long somebody's going to live. I've got patients who I thought were going to live days and they're alive weeks or months later. I've got one patient who I thought was going to be dead within 3 months, and he's alive 25 years later and living well. We were all completely wrong. Medicine is a probabilistic art. And even in the last 48 hours of life, when you think it's barn door, no, 3% of people improve and don't die as you expect them to. So we're pretty hopeless at even predicting prognosis. What about capacity? As we've heard already, depression and hopelessness are mutually reinforcing. Major depression is present in a lot of patients, and medication and metabolic changes impair capacity too. And about a third of people with motor neurone disease, which people think doesn't cognitively impair you, actually does. It is not easy and it fluctuates, and you cannot assess capacity for that decision at that time just on a one-off. You have to know the person. So we're pretty poor at that too. And what about voluntariness? This is the one that worries me most of all, because we can't detect coercion in families. We can't detect pressures. If we were good at picking this up, we would be picking up all the elder abuse that goes on, all the domestic abuse, all the financial abuse. We as doctors don't. We are trained to believe people, believe what they say. We have a low index of suspicion, I'm afraid. But unfortunately, not all families are loving families. And families get exhausted, and people get frightened of their family not loving them anymore. So we're very poor. We don't know what goes on at home. And if you think about someone traveling from the north to the south, how on earth would an assessing doctor have a clue what went on in that person's home? Now, just to be clear, there is no law against stopping treatment. You cannot be treated without consent. And whenever we stop a treatment, we do it because we're weighing up whether the risks of it and the burdens of continuing with it are outweighing the benefits. When the benefits aren't there anymore, it is meddlesome and burdensome to carry on with it because the risks and the burdens outweigh. So let me try to explain that fairly graphically. Think about somebody, say, with motor neurone disease who is being ventilated. They, with positive pressure through a mask or through nasal cannulae, and they would have died without that additional ventilatory support. They would already be dead. You have kept them alive. When they say enough is enough, they want to stop, or the decision for whatever reason is taken that this is now becoming futile. You stop. All care must continue for that person as they die, so that they die gently and peacefully. You don't just stop the ventilator and walk away. What about, though, if you're administering euthanasia or giving them the drugs that they take? You have only one intention: to end life as rapidly as possible. And that might be months or years before natural death would have occurred. You're cutting life short deliberately. So what do? Well, you either give them a massive dose of barbiturates, lots of tablets to depress respiration, so they actually have an anoxic, that shortage of oxygen, cardiac arrest, and die. You just depress their respiration. With euthanasia, what do? You inject a short-acting anesthetic. You may add curare to completely paralyze them so they can't breathe and they die of asphyxia. So I always find it slightly strange that people are so terrified of dying of asphyxia, and yet that's actually what you do. You depress respiration so the person dies. So what about this bill? Well, as you've heard, it just says terminally ill, but their definition is dreadful. It's completely wide open. How on earth somebody could assess a clear and settled intention if someone's traveled down, particularly not known even in the area, I don't know. And this business about being a resident on the island of Ireland obviously has implications for the doctors in the north. Terminally ill, as Robert has explained, and I think it is really important to emphasize this, this could be anybody. This could be somebody who's got a little bit of MS, a first attack, second attack, that's progressing. You know it's going to progress, but they might live 20 years, 30 years with the disease. And they're likely to die as a result of that disease in the end, or complications related to it, such as a chest infection. Again, that our neurology colleague here, John McKinley, just outlined so clearly. They'd all qualify in this. The diabetic who's insulin dependent, well, that diabetes is going to go on, and they're very likely to die of complications of it. And symptomatic treatment, they're saying that isn't to be regarded as curative. Well, the valid declaration, the person's medical records, and seeing them, as has already been outlined, what's the position if somebody travels to the south? Again, thank you, John, you put it beautifully. And as I said, coercion or duress, how do we know about it? And informing somebody about palliative care or hospice is completely different to experiencing it. I've had literally hundreds of patients who've said to me, I never believed that you'd get on top of my pain. I never believed that I could feel so well again. I never believed I could get home again. I never believed I could get to such and such, whatever the event was that they were looking forward to. Just like the man the other week with his daughter's wedding. Oh, I don't think I'll make it. I don't think I'll make it. Well, we just a few little adjustments, and he made it fine. It was lovely. So what's the process? As I said, in the bill, it isn't just that the patient takes this whole pile of tablets or drinks a tumbler full of barbiturates. No, you could assist them. So you could actually sit and feed the tablets into their mouth, crush them up, prepare them, and so on. You could connect them to a pump if they've got a gastrostomy tube. And so all they have to do is turn the pump on. Or you might be injecting lethal drugs. And they put in the bill a cooling off period of 14 days. But actually, they say if you think the prognosis is less than a month, well, you can cut it down to 6 days. That's nothing in the life of somebody who's adjusting to a situation they're in. We know very well that at the time of diagnosis, distress is often far greater than it is later on in disease, and it's particularly severe when they get a recurrence. So the person with cancer gets metastases, they're devastated. The person with MS gets a severe attack, it's obviously progressing, that's devastating. So what are the concerns of the doctors in Northern Ireland? Well, they're very concerned that there aren't any safeguards in the bill. There aren't any for patients, there certainly aren't for family. The person doesn't have to have informed their family what they're doing, and there certainly aren't safeguards for any staff. There are the constitutional implications of 2 jurisdictions, obviously, but there's this ethical problem of a doctor-patient power imbalance. Patients tend to believe what we say. If the doctor says, there's nothing more I can do for you, of course the patient plunges into despair. If the doctor says, right, these are the problems, this is what we're going to address and how we sort them out, you give them hope, realistic hope. You're not lying to them, you're not leading them up the garden path, but actually they believe us, and nobody should underestimate what happens if a doctor says, yeah, I agree with you. I'll agree with you to have assisted suicide or euthanasia, because they give the message that I know that what lies ahead is so terrible that I think this would be the better way out for you. There are weak definitions in the bill. As Robert has said already, law guides society. It sets the tone of what we do. We see it time and time again. Permissive laws make whatever they've permitted happen more often. And there are legal implications, because this is putting doctors in a position of judging things on which they have no evidence, no ability to judge. And doctors have a duty to prevent suicide. So they're really conflicted here. What are the specific problems to Northern Ireland doctors? Well, what happens if they take their case notes south? Will they then be accused of assisting in UK law? Which jurisdiction would it be judged under if they bring the tablets home? As I said, they can't detect coercion. There's no conscience clause in this. And we know from Canada that actually doctors now are being told that they have to offer the option to patients. There isn't a conscience clause that's worth the paper it's written on. Mental health assessments, they're not in this bill, but they're terribly important. As Robert has said, the way that somebody perceives themselves isn't just a straight capacity assessment. And you have an additional problem. You've got a lot of people with post-traumatic stress, and all of that bubbling up under the surface comes up when they're ill as well. Also, people have impulsive behavior. As somebody outlined a study of the survivors of those who jumped off the bridge in San Francisco. And people being made to feel a burden, people who are lonely. We've now had people in Canada who've opted to have euthanasia because they couldn't face another lockdown. We also know from places like Canada, it's a good cost-saving measure. It frees up beds. It does not mean that you get more care. You don't get diversion of costs. And we know that there is not enough palliative care currently to meet the needs of the population. And I think you've got less palliative care provision in Northern Ireland as specialist palliative care than there are in other places such as Wales on a population basis. So you're lagging behind anyway, and the same applies in the south of Ireland. What about the BMA? Well, the BMA surveyed its members, and they found doctors are members of the population. And of course, they included medical students who are not yet qualified and those who are retired, who may well actually know remarkably little about modern palliative care and may be quite frightened by the appalling that they gave to their patients over the years. Because it was really awful when I qualified. Care of dying patients was shameful. And I know, but I'm not that old. In Ireland, though, there is less support, interestingly, than in the other jurisdictions of the UK. And there are decent numbers here, so nobody can say this was only a tiny number surveyed. Or when we though take all of the BMA views, because I couldn't disaggregate some of these finer details from that Northern Ireland group, I'm afraid. It's not in the report, that data is not available. When asked though of those people who were suggesting that they would support a law to change, and remember here it's around about 37% overall, it drops. Only about 2/3 would actually participate in the process. That's about doing an assessment and prescribing. But when you ask them, would they actually administer, i.e. inject lethal drugs, it drops even further to 2/3 of those who would participate. So when it comes to the reality, doctors actually don't want to do it. And when you look at doctors who have a license to practice, there is less support than there is if you include medical students and those who've retired. Now, what about those, though, who look after dying patients all the time? Palliative medicine, the highest opposition to participating, but also opposition in oncology, rheumatology, gastroenterology, general practice, and geriatrics. These are people who look after dying patients, and much less opposition in things like dermatology, public health medicine, people who really don't look after dying patients. So it's all a bit theoretical and they're influenced by the press. So there are other agendas though. As Robert said, this is a very poorly thought through bill, and this is a backdoor way as well, I think, to introduce physician-assisted suicide and physician-administered euthanasia across the UK. We have written a little book about it and it is available. It's called Death by Appointment. This is the image off the front of the cover, and it is a rational guide to assisted dying. It is analysing the issues very much as Robert has spoken about. I've amplified a bit more on palliative care here than we have done in the book, but thank you for listening.
Thank you very much, Ilora.